All right, we have a very exciting session for you coming up. I'm just going to introduce our two presenters very quickly and dive right into it. We have Hugo Campos, who's from Research Partner and is a patient advocate, long time's worked with all of us and many other research projects as well. Hugo will lead you through a very interesting demo here. And also JP Pollak, who's with the Commons Project, and somebody I've worked with for, I don't know, well over 10 years, open source infrastructure, Jupyter Health, and so forth. JP will comment on the technicalities of what's going on, but Hugo, I'm going to hand it over to you directly.
Thank you. Thank you. Thank you, Dr. Sim, and thanks, everybody. I'm going to quickly go through this is a pre-recorded demo, so it's efficient. My name is Hugo Campos, and I'm going to hit play here and describe this. And I'm a person living with hypertrophic cardiomyopathy. I'm also a caregiver to my 95-year-old father who lives with my partner and I. Let me take the audio here. What I'm hoping to do today is to show you how I have been using the Health Skills app to download my dad's records from 3 different providers and then feed them into Claude to have them analyzed. So Dad is 95 years old. He has multiple conditions. He has chronic atrial fibrillation. He has heart failure with preserved ejection fraction. He has a history of pericardial effusions. He has stage 4 chronic kidney disease and an inflammatory process that goes back over a decade that was never properly diagnosed. In 2021, he was admitted to hospital with a pericardial effusion that required pericardiocentesis and later surgery for a pericardial window. And he was sent home in hospice care. Thankfully, he recovered, and today he's doing relatively well, although he's having some trouble healing a wound on his left ankle due to venous insufficiency in his legs. And so he's a complex case. I tell you all these things because he's complex, and he has given me permission to share his medical information here today. So let's get going here with the data. I'm going to download the data using the Health Skills app, and going to the Health Skills website here, and now I'm connecting to my dad's connecting the app to my dad's 3 providers, and it's Sutter Health and John Muir Health and Stanford. I'm going to start here with, I believe it's John Muir, yeah. And the web-based app is open source. It's developed by Josh Mandel and uses Smart on FHIR to export records locally. And what I'm doing here is connecting to Dad's first provider, John Muir. He uses OAuth to connect. And JP, let me know if I'm misspeaking on any of the technical stuff. And so now, after you log in, you can select what type of data you want to export and how long you want the app to have access to the record set. I'm now connecting to Sutter at the second app. And the idea here is that I'm connecting these 3 different providers and pulling the data down, which I will download into my hard drive in just a second here, 3 separate JSON files, 1 per provider. Now I'm connecting to Stanford, and this is a process that takes a little longer than I'm showing here. This is sped up. So it can take quite a few minutes sometimes to grab if it's a large record. But once the records are connected, then I'm able to download a zip archive, which I've done here in the demo, containing the 3 JSON files, 1 for each provider. You see all 3 files in there. There's also a FHIR guide MD, a markdown file, and a skill.md. Those are markdown files. The FHIR guide tells Claude how to read the JSON files containing the records, and the skill MD markdown file tells Claude how to behave. And now I'm switching here to Claude, and I'm going to show you 3 questions. The third one we'll do live, if it works. And so, I use Claude Co-work because the files are local to my hard drive. So, and these files are quite large, and sometimes they time out the server. the payload is too large. So what I'm doing here is telling Claude to access the health skill demo folder. I've done that. And now I am prompting it to read the skill MD and then read the JSON files and then use the FHIR guide to interpret the data. And this is a process that can take a few minutes too, depending on how big the file is. And mind you, I'm using Opus 4.6 with extended thinking. I find that the quality of the outputs are better with a model that has a more capable model. And so, so I'm asking here the first question. I'm going to pause here for 1 second so I can catch up. And so the first question that I'm asking Claude is something relatively simple. I'm asking here for Claude to look at medications that Dad is currently taking and if there's any known drug interactions. And it's listing the medications. And it points out a few interactions. Most of these, or some of these have been addressed already. For question number 2, I'm now asking something a little more complex. I'm asking, I want to know if, given Dad's chronic kidney disease, stage 4, with eGFR of 27, if any of his current medications could use a renal dose adjustment. And this demo was recorded a week and a half ago. We've had an appointment, and these were addressed since then. And again, Claude here points at some of the critical and high interactions that need attention. And it talks about the ibuprofen and hydrochlorothiazide. We've stopped the ibuprofen, so that's no longer an issue. He stopped also the hydrochlorothiazide, and he's now taking Lasix as needed. And now for the question number 3. And I was telling Claude there that to update the information. And you can, the idea here is that you can actually have an interaction with it. So for question 3, we're just gonna switch here to Claude and ask the third question live. And I prepped this by doing this earlier today here in this room. And so what I'm asking Claude here, if you look at the prompt, is what I'm asking is to look across 15 years of records from multiple health systems. I'm going to hit enter. And because this may take a few minutes. I'm asking Claude to look at across 15 years of records from 3 different health systems and asking if there is a unifying diagnosis that could explain the recurrent pericardial effusions that have been going on since 2013. And some relation to the inflammatory joint episodes that are attributed to gout and the chronic kidney disease progression, the heart failure with preserved ejection fraction, which is another clue, with potentially hypertrophic phenotype. I have HCM, but my dad was never diagnosed with hypertrophic cardiomyopathy, and the non-healing ankle ulcer with normal inflammatory markers. So I'm asking Claude to consider diagnoses that may have been missed or were inadequately explored. I suppose while it's going on, I'll let JP provide some context on what's happening here.
Yeah, thanks, Hugo. This is super cool. So for those of you who are using LLMs every day, who maybe work in health informatics, et cetera, maybe this doesn't seem that exciting, but I can assure you that what's happening here is stuff that has not gone on until very, very recently. Until even just, I don't know, weeks, months ago, we didn't really have the capabilities to do exactly this sort of thing. So 10 years ago, even we go back, you couldn't get access to your healthcare records in a computable format in order to do this kind of thing. In 2016, we passed the 21st Century Cures Act, which basically said that your healthcare providers and the information IT vendors, the health IT vendors that service them, i.e. EHRs, had to be able to provide patients with their computable health information via an API. And those APIs had to allow patients to download those health records to the application of their choice, something like this or so on. The next couple of steps, so one, they picked some standardized protocol So you heard Hugo mention Smart on FHIR earlier. So FHIR is basically a gigantic framework, set of standards, protocols, gateways, tools, and references for describing all of the kinds of things that can go on in a healthcare setting and in a patient's life. And Smart on FHIR is one particular tool in that large toolbox that allows an application to connect to a data source, going through proper authentication protocols, understand all of the aspects of the data that exist there, the tools that are going to be available to that application, define application scopes, like this particular app would like to get access to medications and procedures, but it doesn't need the rest. And then fetch the data, and do so in a way that is secure for the patient and private for the patient, but all the while facilitating these kinds of data transfers and interactions. The next thing that 21st Century Cures and this previous work defined was something called US CDI, which is the US Core Data for Interoperability data set. You can Google that and see the most up-to-date version of what exists in US CDI, but it's effectively all of the stuff about a patient or a person that one needs: procedures, medications, care plans, conditions, and so on. And the fact that we have these two definitions, right, a set of standards and a way to describe the data and the way to get it out, as well as a set of required data elements that all of these applications and digital services need to be able to access, we're ready to go, and we can do things like this. So this was 10 years ago. In the ensuing years, right, we saw some uptick, right, the various EHRs who were required to do this. Early ones were Epic and Allscripts, followed by Cerner, Athena Health, and so on. We saw some mobile applications and some web-based applications. Apple Health adopted this technology in 2018, Common Health on Android shortly thereafter. But really, the uptake was not that tremendous, right? Aside from, particular patients who had really complex histories, folks with rare diseases who needed to get access to detailed records, it's just not something that had been mainstream. And one of the reasons for that is a lack of ability to compile the data and make it actionable in ways that are interesting and useful for people, right? This effort that Claude has undertaken on behalf of Hugo represents synthesis of data over dozens of years from multiple healthcare institutions. Much of the data in these files are redundant. Sometimes they're at odds with one another. And for simple software to make sense of this, really not feasible or plausible. And so within the last year, the development of these particular models, as well as contributions from our friends like Josh Mandel that Hugo referenced, who just happened to be the original architect for that Smart on FHIR technology that we mentioned earlier, we end up with sets of tools that look something like this, right? So we now have what it takes to pull the data into one unified location. We know the structure and composition of those data, and we can train a model like Opus 4.6 here from Anthropic about the nature of those data and give it a chance to answer these kinds of really complex questions. Now, as you can see, this is also something of what I would describe as the science project phase of all of this work, right? So, this is something that most people aren't going to just be able to do, right? Certainly if you put in the effort and watch enough YouTube videos and have friends like we do who work in health IT, it's feasible for you to do this. But for the average person, making all of this stuff fit together and work is somewhat difficult. We do have off-the-shelf models from OpenAI, for example. There's now ChatGPT for Health, right, which will let you use a clear identity process to go through and provide your identity. Go try and find healthcare records for you throughout the ecosystem. And that's slightly streamlined, slightly easier version of this, but there's definitely some privacy trade-offs with that. Not sure how many people are comfortable doing exactly that sort of thing today. Are we done here?
Yeah.
Yeah. Okay, great. So with that, I think we're now in a place where we can start to look at this, and then we can answer some questions that you might have after Hugo has had a chance to tell us what amazing findings Claude has bestowed upon us today, and if they're even the same as the ones that he bestowed upon us yesterday.
It is. Yeah. Thank goodness we're So we've run this a few times, and we always get the same answer. So what? So the AI does confabulate occasionally, but not this time. So what Claude suggests is the possibility of wild-type ATTR, cardiac amyloidosis, and this is something that was potentially brought up or discussed, I think, back in 2017. Although it wasn't really pursued, and don't know if this would change anything. If it's up now to us, Dad and I, to sort of decide. I brought this up to him, by the way, and written in Portuguese, which Claude, which is his language of preference. And so, and this is, has been a decision now needs to be made whether or not it makes sense to pursue confirming this diagnosis. If there's any way that the way that we manage his health that would change, medications, interventions, anything like that. And so I'm planning on bringing this up with cardiology. We have an appointment with nephrology this week. I'm going to bring it up, and in 2 weeks with cardiology. So it's giving us avenues, and I think I often tell folks, AI is not really about providing answers. A lot of times it's not an oracle, and patients should approach AI with, I tell fellow patients, approach AI in this way. Don't think of it as it's not an answer machine. It's really a thinking partner, and it really is a tool that's not there to provide answers necessarily, but to help you think and help you ask better questions. So at least that's my approach. I think that kind of wraps what we had for you guys. If anybody has any questions, I'll be happy to ask questions of the data.
And if there are no questions, I'll just keep talking about history. So.
This is really cool. Thank you for sharing it. One question that I have is, I feel like you have to have a good basis and background knowledge to be able to ask clarifying questions. And I know in the last panel it was brought up that you could use the LLMs to kind of sense check your understanding or level of health literacy. I guess, how do you think about bridging that gap for someone who may not have the same background? Or I feel like us in this room, we're pretty health literate, but a lot of people are not, or wouldn't know how to answer or ask these questions.
Yeah, I think I understand. I think I heard the question. So, so to answer that, I didn't start off with health literacy, right? So, I don't have I'm not an engineer. I'm not a doctor. I'm not a clinician. I don't have any formal education in life sciences or engineering. So this stuff that I learned from picking it up. And so if I can learn it, anybody can learn it. And so it really is a matter of using these tools and familiarizing yourself with it, asking questions, and I believe it's a skill that we all sort of will or can learn how to develop. And so does that answer your question? So one more data point here is that for Dad, for example, for him, so the way the AI talks to me is not the way that it's most useful for him. And so I usually use the AI to generate the outputs in Portuguese, and I have done this, and he has experienced some cognitive decline, and so I try to make it simpler, and I ask him, I engage with him, and I say, does this make sense? Do you understand what this means? And so what do you want to do about it? And so, and that's kind of how we go about it, but it's all the answers are in the AI, as it was pointed out earlier today.
Hi, great presentation. My name is Shinra. I'm a researcher at UCLA and a software engineer at Uber. I think my first question is similar to the previous question. So what is the audience that we're having for this tool? But I think you clarified on that. The second part is about privacy. I know you briefly mentioned that this will have a slightly better privacy than OpenAI. Is it that we did the encryption part while we're pulling the data from those tools, or like, can you explain the process? Thank you.
Yeah, the privacy question is interesting. So in this case, the author of the set of tools that Hugo used to pull the data into his desktop computer and to start being interrogated by Claude made a bunch of specific choices, right? Those choices include making sure that the data were completely ephemeral in his web browser, right? So when he was at the Sutter Health website and the data were loaded up there, right? They didn't get downloaded anywhere. They didn't go live in some server somewhere that was, could be added to other people's records, those kinds of things. And then they were downloaded, encrypted to his hard drive, right? So that part is somewhat straightforward, right? The next part is where things become a little bit less straightforward, right? So certainly if you work at an organization that takes the privacy of their employees or their patients that they see or their customers' data very seriously, they set up models in such a way that they're walled off, right? So data can't be used for particular training purposes. Data can't be can't cross with data from other purposes, things like that. But when you are sort of letting your data leave those confines and go to, one of the commercial software applications, you can read their terms of service, and if you're a lawyer and a software engineer, maybe you can figure out what they're going to do, and maybe you determine that those, privacy choices that they've made on your behalf are okay. But they can also change their terms of service tomorrow without much recourse, right? And, that's not necessarily an evil thing to do. It's just something that happens in the nature of these applications.
And to add, yes, and to JP's answer, doctors adopt AI at the speed of trust, and patients adopt AI at the speed of desperation. So a lot of times privacy is not the main concern if you're trying to solve a problem that needs a solution.
Hello. Hi. I was wondering if you could expand on what you were saying about privacy and how you guys think about the trade-off between like the OpenAI Health versus Claude, which is also not very private, and compared to like using a local LLM on someone's device instead.
As opposed to using
like a local LLM or something like that. Yeah, I mean, the technical answer I think is shorter and less interesting, right? I mean, the technical answer is that, we can always make choices for nearly everything we do that are more private than others, right? And so really you're balancing the gains that you can be had by doing something in a less private space. With the internet, often that's choosing to pay for something versus getting it for free. With tools like this, it's choosing to get the most sophisticated models on the market versus something that's maybe less sophisticated and run on your laptop. But then there's a whole lot more to it than that, which gets to the desperation point that Hugo referenced, of course.
Yeah, and for me, there's a couple of reasons. One is using the most capable model I can get my hands on, and the fact that I can't install a large language model. I don't have the expertise to run it on my local machine. So it's, for me, it's a, I also have an idea on my mind that privacy, and at least it's my take on it, that our perception of privacy is a little skewed and not really aligned with reality, and anybody can buy data about me. And so where I am in my life, not concerned about not finding employment because of a chronic condition. I'm not concerned about, there are things that are not a concern for me. And so I don't care. And Dad doesn't either, I've asked him. I guess I get it from him.
Hi, thanks for the fascinating, over here, for the fascinating demo. I was wondering if you could tell us a bit more about your experience learning to talk to Claude or talk to an AI about exploring these health records. And maybe if you're thinking back to some of your earlier experiences, if there were questions that maybe led you down an unexpected path, if there are questions you learned to start asking. A couple of examples I think would be really cool to hear.
Yeah, for me, it's been a gradual but very intense use of generative AI ever since ChatGPT came up with 3.5 for the general public in, I guess, November of 2022. And I jumped right on it. I was like, wow, I've been talking about patient agency and autonomy for years. This will change everything. And slowly I started learning how to give it context, and first giving PDFs, then learning how to convert PDFs into text, and then markdown files, and more recently sort of graduated into JSON files, thanks to the ability of being able to download those types of files. But it's been a gradual but quite intense. I use these tools all the time. I use everything I can get my hands on, including DeepSeek. I'm completely model agnostic. If you send me something, I will give it a shot. So, unafraid, perhaps one day I'll regret it, but haven't yet. It has generally provided value. So it has been a good experience for me. So not a bad thing at all. And so it's been a while. And I always, well, I can go on. I can go on forever, but it's, I guess, I'll tell you one last thing. I tell patients, there are three things sort of there are critical sort of foundational domains that we should master in order to use these tools effectively. First is knowing context. So it's about data. It's about understanding a little bit. The more you understand about that, the more you can be an informaticist or informatician, I suppose, the better off you are. And so the other area is the other domain is understanding these tools. What tool is best for what? Is this a job for Claude Sonnet? Is this a job for Gemini 3.1? Should I put this on NotebookLM? Should I use Llama? What's the tool here for this particular job? And the third thing is maintaining your agency. It's critical that people maintain their ability for critical thinking, and I don't trust in the same way that I trust nobody. I don't even trust my own thoughts. I don't trust AI either. And so I try to make the best that I can with the tools that I have available to me. Doesn't mean I blindly trust it. I use AI, again, to ask better questions, not to provide answers. Okay. Thank you very much.